Hello everyone, and welcome to the 21st edition of Practo Connect webinars. Before I start, I want to give my congratulations and best wishes to everybody on the birth anniversary of Netaji Subhash Chandra Bose today. We have just started celebrating the anniversary after a long time, a much awaited birth anniversary celebration for all of us. So getting back to the topic on hand, today's webinar is on Omicron, what we know so far. Now this Omicron fueled third wave was awaited. We knew that a third wave is going to come in, but nobody expected Omicron, a variant with so many variations as compared to the previous Delta variant, that it came more as a flash flood than a wave. Started off with a few hundred cases in India in early Jan, quickly went up to 2.5 lakh cases every day by mid-Jan. So it's come like a swell, not just a wave, a swell, a flash flood. And cases have been increasing every day. There have been some changes in treatment protocols. There have been some changes in the symptoms in how the patients present. So to understand how the virus has changed and the clinical implications of this variant, we have with us two very esteemed speakers. First, I would like to introduce Professor Ravi. Professor Ravi was the former head of neurovirology at NIMHANS and is a member of the COVID-19 task force of Karnataka State. Presently, Professor Ravi is the head of R&D at Tata M&D, and they've recently come up with a new testing kit called Omicron to confirm the presence of Omicron infection. Also with us, we have Dr. Rajesh Swarnakar. Dr. Rajesh Swarnakar is the Chief Pulmonologist and Director at Getwell Hospital in Nagpur. He's also the Secretary of India Chest Society. He's got multiple publications and he's written chapters in respiratory medicine book of and PG Guide. He's a PG Guide of MD and DNB examiner, Principal of Academy for Clinical Research Training, Director of Unique Clinical Research Private Limited, President of Getwell Sanjeevani Education Society. Good to have you, Dr. Rajesh. It's a pleasure having you.
Thank you, Neeraj.
Thanks for making the time, sir. I know today is a busy day for you, a wedding in your house, but I'm so glad to have you here.
Thank you.
So I would like to start with Professor Ravi. Professor Ravi will be telling us about the viral aspects of Omicron and how it has been evolved over the past month or so. Please, Professor Ravi, could you share your screen now?
Can you give me permission to share the screen? Yeah. I hope you are able to see my screen, Nilesh.
Yes, sir.
Good morning, and let me thank Dr. Nilesh, a dear friend for the last year and a half, for having me speak on evolution of SARS-CoV-2 and public health challenges. We all know that SARS-CoV-2 is a RNA virus. It belongs to the family of coronaviruses. The virus measures approximately 60 to 120 nanometers. It has an outer envelope and an inner core. The outer envelope is embedded with a very important protein. On the left, you can see it as a yellow colored spherical protein that is pin-shaped. This is called the spike protein. The spike protein is the most important protein of the virus because it helps to attach to human and animal cells. Secondly, the entire protection against this virus is invested in this protein. So all immune responses are primarily directed against this protein, and that is what gives protection. The genome or the genetic material of SARS-CoV-2 is 30,000, approximately 29 to 30,000 nucleotides long, and it is a single open reading frame, meaning it translates into a huge protein, which then is broken down, assembled, the virus is released. It's a positive standard genome, meaning if you introduce the RNA into a cell, it will directly go into translation and produce proteins. Over the last 2 years, this virus has surprised all of us by continuously mutating, and these mutants are referred to as variants of SARS-CoV-2. I would like to introduce 3 terminologies when I'm talking of variants in SARS-CoV-2. Variant of interest, variant of concern, and variant of high consequence. Variant of interest is a variant that can alter its behavior when binding to receptor. It can reduce neutralizing capacity of antibodies. It can reduce the efficacy of treatments. It may or may not have an impact on transmissibility and diagnostic testing. And of course, it is limited to a geographic locality, not spreading across the globe. But variant of concern is the one that everybody is worried about, primarily because of increased transmissibility. It spreads across the globe very quickly. It may or may not produce more severity in symptoms. We all know that Delta caused severe symptoms. It is a vaccine escape in many ways. That's how it's able to spread fast. And of course, the efficacy of treatment also varies. There are 5 variants of concern described in the last 2 years. The original Wuhan virus significantly mutated late November 2020 or September, October 2020. And the first variant of concern was detected in the United Kingdom. It was called Alpha. Actually, it is a very complicated nomenclature, B.1.1.7, but those are technical language which people cannot easily remember. So the WHO stepped in and called all the variants by Greek alphabets. Subsequently, a month or 2 later, another variant was discovered in South Africa that was named Beta. A month later, another variant in Brazil called Gamma. And we in India, in early February, March last year, we reported Delta. And of course, November 26th, the WHO announced Omicron. Alpha, Beta, Gamma, Delta are sequential Greek alphabets. You may ask, how come many are missing? No, they are in the variants of interest known as Eta, Iota, Kappa, Lambda. They did not spread across the globe. There is still a variant of high consequence to be described, but the classification is kept alive. Should something more dangerous and virulent emerge, it will be put into that bucket. So we are concerned primarily of variants of concern. One thing I want to point out is even after a variant emerges and spreads, that is also undergoing continuous change. We call them in technical language sublineages. For example, if you take Delta, there are more than 40 to 50 sublineages called AY1 to AY2. So after a variant emerges, it also continuously undergoes change. That brings us to the question, why do variants emerge? RNA viruses have an advantage known as mutation. That is because the enzyme that makes copies of the RNA, known as RNA-dependent RNA polymerase, makes mistakes. Makes mistakes because it lacks proofreading ability. It does not have the ability to detect errors. Like we say in editors, they have to, anybody who edits a manuscript and English editor detects mistakes. Now, this ability is poor generally in RNA viruses. However, coronaviruses have a good proofreading ability, but still they do make much less mistakes than influenza or HIV. The second reason why variants emerge is because of immune pressure. If you look at the history of variants of concern, the first one emerged in UK, Alpha, in late last year, late 2020. That's as soon as vaccinations were introduced. Now, vaccinations, the immune response can put pressure on the virus to escape the immune system, and that's one reason why it happens. Each time the virus multiplies, there are mutations, but all of them do not translate into a change in amino acid. And even if there is a change in amino acid, all of them do not alter the behavior of the virus. So mutation basically is a continuous process, very integral to RNA viruses. The mutants were being classified in various manners, and then there was an international committee that sat down and said we will use only one or two particular types of classification. Currently, the most widely used is a pangolin lineage, which actually gives alphabets followed by numbers. The parent Wuhan virus was called A. Somewhere in February 2020, it mutated. One major amino acid changed and became more infectious. That was called B. That subsequently started mutating further. It was called B.1. And B.1 mutated further. It was called B.1.1. So that's how the lineage description goes. And on the right, you see the phylogenetic tree. Based on the genetic sequences, a software assigns it to a particular branch of the tree, and if the branch deviates significantly, then a new lineage is formed. This is the genomic map. In the middle, you can see that the thin light lines descending from the horizontal bar denote the mutations. Maximum mutations are occurring in areas that is found on the surface of the virus, namely the spike protein. We all know that last year, Delta lineage was detected in India. And when people started tracking it, being less than 1% in January, February, by April, it completely took over, meaning it spread widely in the community, and almost 90 to 100% of all viruses being sequenced were Delta. So when a new variant of concern emerges, it spreads across the communities because there is no specific immunity to that particular variant. This is the variant mutation map. Alpha had lesser number of mutations. Beta also had similar mutations, but one or two unique, and so was Gamma. Delta had a completely different set of mutations, as you can see. Then came Omicron on November 26th. It has a whopping 53 to 55 mutations. In that, the middle portion, which is the green in the bar on the left, is the region of the spike protein which engages with the receptor. RBD stands for receptor binding domain. And in the spike protein itself, there are 36 mutations. Now, this significantly altered the fitness of the virus. It started entering human cells faster, multiplying to a much greater extent, thereby making it 8 to 10 times more infectious than Delta. Delta was 40 to 50 times more infectious than Alpha. So you can see as the virus is evolving, it's getting its act together and being able to interact. On the right, you see a graph. In a matter of 3 to 4 weeks, 3.5 weeks to precisely, in South Africa, the red line you can see is more or less vertical. What is it telling you? That among the percentage of samples sequenced in South Africa between November 11th and November 26th, it went up from single digit, 5 to 6% to 90%. That's how WHO declared it variant of concern. It is, of course, spreading across the globe, irrespective of the region. You can see almost all regions, the curve of Omicron cases is increasing great deal. And these are the geographic map, which depicts all variants. Remember, Omicron is spreading fast, but still other variants are circulating. That's how you have various colors in this pie diagrams. At this point of time in countries, it varies between 50 to 90 or 95% is Omicron. And the same thing depicted as a graph. Delta dominated for 8 months, which is the indigo blue you are seeing in this graph. And you see towards the right of the graph, there is increasing, purple is Delta. It dominated for 8 months. Indigo blue in letters GRA depicts the Omicron, and it is increasing across the globe. What are the consequences of emerging variants? A, ability to spread more quickly, so it can sweep across areas. B, they can either cause mild disease or severe disease. Delta produced severe disease. Omicron is associated with mild disease. They all can evade immune response. They can cause breakthrough infections in vaccinated people. Classical example is Omicron. If you take the data today and have a look at it, it will tell you that Omicron infections are much more common in double vaccinated people. So the vaccine is disease and death. Thank God we have made a very decent coverage of vaccination in India. Decreased susceptibility to therapies, especially to monoclonal antibody cocktails. If you take Omicron, the existing monoclonal antibody cocktails, about 4 are there. 3 do not work against Omicron. There's only 1 in the US, and that's very expensive, not available outside of US. And of course, impact on diagnostic tests. What are the challenges for public health related to variants? If you look at the current scenario in India, Omicron is spreading rapidly across the country. Like other, the second wave, it's moving from metros to smaller towns. Over 350 new cases are being reported yesterday and today. And among them, only 9,000 have been confirmed as Omicron because gene sequencing used to be the only method. And remember, even this 9,000 is samples collected 5 to 7 days ago. But we are assuming everything is Omicron. Most cases are mild, hospitalization are lower, thank God, than the second wave, and mortality is also low. So now there is a raging debate that is occurring whether we should assume all cases are Omicron. And based on this debate, states are altering their testing levels, which in my opinion may not be the right strategy. Let's look at the debate. What happens if you assume that all cases that you are seeing every day is Omicron? And what is the argument favoring that? The argument is huge surge of cases we saw is only after introduction of Omicron on December 1st into India. And as Dr. Nilesh said, from January, it is spreading faster. Mild symptoms, no lung involvement. Gene sequencing is very expensive, so there is no need for testing everybody. There is no need to monitor mutations in the virus. Health system is not stretched. The mortality is low. Only unvaccinated people are at high risk of developing severe disease. Very few of these people who are elderly and comorbid are the ones who develop serious disease. It can avoid a monoclonal cocktail. There's no need to impose severe restrictions because economy is important. And also, there's no need to waste money on testing. That's the people who say no need, assume everything is Omicron, don't do anything. But the people who are against will say that, look, where is the evidence that all the 350,000 new cases are Omicron? Agreed, gene sequence cannot be done in everybody. But there are other alternatives to gene sequencing. There are now RT-PCR tests. Every day, a new RT-PCR test for Omicron detection is getting approved. Public health principles mandate that in an outbreak, at least 10 to 20% of samples should every day be tested. You cannot give up testing. Testing is an important strategy and tool. You need to know if it's Omicron because clinical protocols vary. If it is Delta, then you may still have to have options of remdesivir, steroids, oxygen supply, keeping hospital beds, and so on. If you do Omicron testing and find it Omicron, there is a huge sense of relief to the patient and family. You can avoid expensive monoclonal therapy because it doesn't work in Omicron. There's a risk of generalizing assumptions that everything is Omicron, and honestly speaking, interventions have to be policy driven and data driven. We do not have data to say majority of Omicron. We have very little data on gene sequencing, and consequently, the policies are getting flawed. So these are the two debates. I will leave it to you which group you belong to. There are several challenges related to lab testing in variants, whether it's Omicron or the other. There are a number of tests available, and we know the choice of testing itself is a huge challenge. Whether you use rapid tests, whether you use PCRs, whether you use other molecular tests, or whether you should go for gene sequencing. Remember, whichever test you do in a patient who's infected, there is a window during which nucleic acid tests are positive or antigen tests are positive. And that window is 1 or 2 days before onset of symptoms to 5 or 6 days after onset of symptoms. After that, the probability of detecting either the antigen or nucleic acid really goes down. So when you test is also very important. Do the current tests work? Well, the FDA in USA has said it has little impact on molecular tests such as PCR, provided we are using tests that amplify multiple genes. If you use tests that amplify only one gene in a PCR, then your chances of missing Omicron are higher. But if you use multiple targets, and if they are not spike protein, your chances of missing Omicron is very, very less. And it's also this same kind of advisory. They have been following rapid antigen tests and looking at whether Omicron proven cases, the antigen test is working or not. For this, they use heat inactivated samples and keep monitoring. So the good news is current tests seem to be okay. They are not missing Omicron. The other challenge related to testing is international travel. Different countries have different policies. Large number of people are moving across the globe. Testing them in a fast manner and allowing them to go home is also a challenge. How do you confirm Omicron? Currently, you have gene sequencing as the gold standard. It's extremely expensive, 5,000 to 10,000 rupees. It takes 5 to 7 days, and you need large number of batch testing is done. For a single sample, you cannot do it. And you need trained manpower and expertise to interpret the results. So on this context, at Tata MD, we came up with asking a question, can we have a solution? And we developed an RT-PCR in a matter of 1 month. Here are the timelines. November 26th, Omicron was announced, and By 1st December, we decided to develop a test. By December 7th, we designed all the primers and probes, ordered them, got it on December 20th. 23rd, we filed a patent because it's the first time in the world people are using two strategies to detect a variant. For Omicron. We have used this test not on guinea pigs in the lighter side, but on human beings. And of course, on 4th January, we got manufacturing license, and now we are making this test. This uses two strategies. One, it uses a strategy which is present in other tests. S gene, because of the mutations, fails to get amplified. It's called S gene target failure. But S gene target failure occurs in other variants also. Alpha also has S gene target failure. Some deltas also have. It's not specific to Omicron. We also added a second component where we chose areas with specific Omicron mutations in spike protein, and we detect that. So this combination is unique and nobody has done it. In addition, we also detect the another portion of the gene which is present in all variants. So here is a test that has two outputs. First of all, it will say whether it's SARS-CoV-2 positive, and if it is SARS-CoV-2 positive, is it Omicron or is it not Omicron? All this is a test that has been validated by ICMR, found 100% sensitive and 99.25% specific for Omicron, and 100% sensitive and 100% specific for all other variants, which means it's more or less concordant with gene sequencing, and it can replace gene sequencing. It works on all RT-PCR machines. The workflow is same. You collect a sample in virus transport medium, do RNA extraction, amplification takes 85 minutes, and then you read the result. Total turnaround time, 2.5 hours. The cost is rupees 250 per test. It's useful for early hotspot detection, especially now when virus is moving from metros to districts. Whenever it enters a new district, one has to ascertain that it is Omicron, then you can use this test. It gives a great sense of relief to patients because they have peace of mind that it's a milder infection. Shorter isolation period. If it is Omicron, people can come out in 7 days, Government of India guidelines, and for healthcare workers, and of course for clinicians to predict. Now, this is a comparison saying among the available Omicron RT-PCRs, we are the only product that have dual strategy of S gene dropout and S gene detection, and therefore, and we also continuously have been watching every day the global sequences, which we call variant watching. And we believe that if a test comes positive for Omicron in PCR, there's no need for gene sequencing. On the contrary, if you want to pick up newer emerging variants, you definitely need to prioritize samples that are Omicron negative in our test, but SARS-CoV-2 positive. That's where you'll catch the new variants. So thank you very much. I shared some of my thoughts and I'll stop sharing my slides. I unfortunately have to leave by 11:55. There are any questions, you can put them in the chat box. I'll keep answering them. Thank you, Dr. Nilesh.
Thank you, Professor Ravi. I know you have to leave. So I have a couple of questions here, which I would ask you before you can leave so that, we get the answers for that. Sir, Omicron will be available when? Widely available in the market when?
It's already manufacturer started and those who have placed orders, it's already gone out. Our large-scale manufacturer will start from Monday or Tuesday, and it will be widely available in the market.
Thank you, sir. And you mentioned 250 rupees per test, right?
Yes, to the laboratory, not to the customer, because this is not a test. It is not a self-test. It will not be available in pharmacy. It can be done only in a laboratory, and it's a PCR.
Got you, sir. Got you. And so, sir, just a couple of questions more. What are your thoughts on these vaccine boosters and in Omicron? Does it work? And
Thank you.
what will be the further implications of variants?
Okay. Let us look at it very objectively. Because of extensive vaccination, we are seeing milder symptoms. Look at data from Europe and USA. Hospitalizations have been the same in the third wave, in the Omicron wave. In fact, US hospitals are stretched beyond their capacity. Large number of deaths. India is not having it. There's a lot of vaccine hesitancy in the Western world. Many people have not taken a shot, not even a single shot. That tells you very clearly, Omicron in unvaccinated people behave like any other Wuhan virus or Delta virus. However, in vaccinated people, it produces very mild symptoms. There is no vaccine in the world, Dr. Nilesh, that can prevent infection today. That's being greedy and asking for too much. Okay? Yeah. The purpose of a vaccine is to prevent severe disease and death, and the vaccines are doing it. And thank God, India vaccinated more than 100 crore people, at least one dose. And that's what you're reaping the benefits now with low hospitalization. So that's point number one. Point number two, your question on whether booster is required. We know now from various research studies that antibodies, which are the only marker of protection we are measuring, although cell-mediated immunity is there, we can't measure it easily. They wane after 6 to 9 months. Take my case. I got vaccinated on the first day on January 16, 2021. My second dose was in 6 weeks later. January 1st, New Year gift, I got Omicron infection. It was mine. And I told you, my sample was the first sample tested on Omicron. Okay? That's a side story by itself. So vaccinated people will get infected with Omicron. There is no guarantee they will not get infected, but it will be mild. Then why do you want to give a booster? There is evidence, research evidence that says that if you boost before you get Omicron, then you can avoid Omicron infection. And where do we have to boost? We have to boost the most vulnerable people. Who are the vulnerable people? Across the country are reporting 20 to 30% of healthcare workers at least not coming for work for 5 days. You see? So healthcare workers require. And secondly, elderly with comorbidities, in spite of vaccination, can get moderate to severe disease. So they have been prioritized. So boosters do work. So boosters are being recommended.
Got you, sir. I still have 3 minutes. I'm 2 minutes, and I'm very, very greedy. So I'll ask you one last question before I let you go. So there is this theory that Omicron might speed up herd immunity amongst people. And
one thing I'll tell you, Nilesh, all of us have to learn is to keep our mouth shut with this virus. Every time we make some assumption, it has surprised that it pulls a trick out of its pocket or its hat. And this hat, of course, is spike protein. It removes the hat and changes itself. So I am not going to comment on herd immunity. I've learned one biggest lesson in public health. Is this the variant that is going to cause herd immunity? It may cause herd immunity for Omicron, but not for the next variant if God forbid it comes again. So let's not ever entertain it is going to become endemic. I'm not going to make a fool of myself predicting. I wanted to start a company known as Viral Astrology. I've abandoned the idea after Omicron came.
Right, sir. So, like always, it's a pleasure having you with us. Sir, one last request. Okay, could you write us a small post on your journey for getting Omicron out? Because I know it's a small 2-month journey, but I'm sure there must have been a lot of hurdles and a lot of adventures you must have gone through the journey. We would all love to read about that. So that is one.
Sure. It's one of the fastest product developments globally also, and
Right.
it is my own career of 40 years. This is the fastest piece of work I've done. Thank you very much.
Thank you, sir.
I'm really sorry I have to leave, but I will do one thing. While I'm on the other meeting, if questions come on chat in this computer, I will still keep answering. I promise you that.
Thanks a lot, sir. A pleasure having you.
Thank you very much.
So we also have with us Dr. Rajesh Swankar. I don't think he's live right now. He might come in, but he's been kind enough to share a video with us of his talk, speaking on the clinical implications of this new variant and how it changes things for doctors in how they treat their patients. So I'll be sharing the video right now. And I request everybody to put their questions in the chat so that Dr. Rajesh can answer it later after the video is played. So sharing the talk by Dr. Rajesh right now.
Hello, friends, and a warm welcome to this talk. The buzzword of this pandemic, which is currently affecting, is on Omicron. So, what we are going to listen to and dwell upon is the clinical implication happened in all over the world is also affecting India with near 10,000 cases of Omicron being detected till date. And this all started when it was first designated as a variant of concern by WHO on 26 November 2021 and has really spread very fast globally because this is a variant which is about 2 to 3 times more contagious than the previous Delta variant. So what is unique feature of this Omicron variant is there are about 30
Come to see
mutations in the spike protein, out of which 23 are quite unique to this variant, which is not found in others. And these mutations appear to have co-evolved with the mutations throughout the viral genome at a very high prevalence. It's closely related to the gamma variant. And the problem is that it's uniquely positioned mutations which are there on its spike protein. This is a photomacrograph of this variant with all the mutations seen. And we are worried that the mutations may make this, and it's making Omicron more transmittable and more deadly, or maybe better. It's better able to evade vaccine protections, which we are so efficiently doing it throughout the world. But of course, there is no proof as yet that the Omicron mutations have these effects, and our situation is still evolving, and we'll come to know. But these are the patterns that we see, that it's more contagious and easily transmittable. And this is because it's a great escape artist. And since the time that was first announced with so many mutations, with about 15 of the mutations located in the receptor binding domain, which is one of the main targets of neutralizing antibodies, thus making them ineffective against this variant. And because it evades the binding and neutralization, the most of this monoclonal antibody, with exception of some, are not effective. There is an antibody which is being studied and which may be released shortly, sotrovimab, which has got some action against Omicron and may be effective. But as of now, it's not available in India. So if we compare the silent feature of Omicron, as we have one study in South Africa, this Omicron virus has got less prevalence of admission to emergency department. The average age at the time of hospitalization has shifted to younger generation. There are fewer numbers who are getting hospitalized, and these are the mostly patients with comorbidities or incidental COVID positives with various other comorbidities, pre-existing also diseases. There is less chances of acute respiratory failure happening in a patient who is affected with Omicron. The requirement of oxygen is also very less. This is in contrast to the third wave, where this was so much prevalent that we ran out of oxygen, but that's not happening. And we see many oxygen beds still vacant despite the surge of Omicron sweeping through the nation. So there are less ICU admission as compared to the Delta wave, and even the death rates are quite less. And this may be because of overwhelming population having been vaccinated, or major population has been vaccinated. And hence, this has been seen that it doesn't affect much to the unvaccinated. It does affect to the unvaccinated, but doesn't affect to the people who have got vaccination. So vaccination is still the best antidote which remains to deal with this Omicron surge till we find better drugs which really deal with this virus effectively. So what we should extrapolate to what we have seen in South Africa is that even if still it is less contagious, it is more contagious and less serious. But if this Omicron affects a large number of population, as it is in India, we also have large number of immunocompromised people due to the age of comorbidities like diabetes, which are high in India. It may happen that when so many people get infected at the same time, because it's more transmittable, it's more contagious. If so many people get affected by the virus at the same time, even if it causes very less serious disease, the sheer number of population getting infected, and even out of that, the number will be quite high, and hence there is a warning that should not be taken as very lightly. And there's another thing that healthcare workers who are caring, they're also getting infected and also getting absent from the work, which again can be a problem. And moreover, because in India now we have the winters, and during this time there is also prevalence of common cold or flu. And this Omicron variety is sharing its symptoms as it happens in flu, and hence it may cause confusion. But it causes nasal congestion, runny nose, sneezing. More people are now reporting scratchy or itchy throat. There's a shivering along with the fever. There's a cough, a sense of tiredness and loss of appetite. Only thing which is very prominently absent is loss of smell and taste, which is absent in this microinfection. And this is a good news because we have seen the Delta wave that people who get affected with loss of smell and taste had more involvement of brain or brain fogging, which will be less in Omicron, which we can consider as a good news if you want. So what are the essential tools for achieving the disease control in this Omicron surge? Is, of course, case finding now is there, but what's being advocated that now the scene has shifted from testing, as we were seeing in third wave, to vaccinate. Hence, there are directives that the self-testing is being promoted, but still RT-PCR and rapid antigen testing are the two tests which are mainstay of case finding. And this is important because as soon as we find that he is COVID affected, we can isolate as per the recommended protocol. We can isolate at home or quarantine into a dedicated COVID care center. And the push is on vaccination for those who have not been vaccinated, for those who have taken only one dose, and for the frontline healthcare workers, those who have completed their 2 doses should now go for a precautionary dose, as has been rolled out recently by the government of India. So why, someone may ask, that why we should test, that we know that it is mild, it doesn't cause problem, and there are hardly drugs which are very effective about it. So why not to just remain at home? So this is because it's very differentiate COVID infection from common cold and flu, and we should test it once the fever comes, because that person may not be affected very badly by the COVID, but if he doesn't know that he has COVID, he is likely to infect others, and the others who can be more prone for the severe disease like comorbid patients, like their elder or persons in their home, they can get infected. Hence, it's very easy to test yourself and isolate so that you prevent infection to others. And hence, once you are affected with the virus, you also take some precautions. And like you see your oxygen level, you know that you're affected and by COVID, and hence you should monitor this. And thus it saves life, as it may allow you to seek treatment earlier and also reduce the disease severity and ultimately death in someone you go and give the infection. So it prevents spreading as isolation is taken seriously and strictly followed. And hence rapid antigen testing kits, which are there available at pharmacies, which have improved over the earlier version and have more sensitive and almost equaling RT-PCR sensitivity now, can be used. And this is very important also because it's not that each and every case is Omicron throughout India. We've got some states in which we are having what we call 2 epidemic, one of Delta, which is less, and more of Omicron. So we do still have cases of Delta, and it may happen. And as of now, there is no way that we can distinguish on just a test kit whether this is Delta or Omicron. So it may happen that someone is affected with Delta, and hence testing positivity has to be increased, and you have to do the test to know. And this is because even now 15-20% of detected cases are due to Delta variant. So depending on your geographical area, it is not basically wiser to not get tested. Hence, this contention of why to test will be tossed up in the air if you just consider all these concerns of not testing. So once you test and becomes positive, there is a recommendation for isolation for our own country. ICMR says that you shall isolate for 7 days, and you can end isolation if a febrile for 3 consecutive days, but still you should follow COVID appropriate behavior because there are chances that you can be reinfected. So there is a very importance of vaccination that has emerged since Omicron surge is being seen. And this is a very recent paper which has come from Israel, and they have done this study in persons who have got 2 vaccinations and then have also been immunized by the booster dose. So they did a study among people who were immunized by booster and who were not immunized by the booster. And what they found is that there's a lower rate of COVID infection after the booster dose. There is also a reduction of hospitalization among those who have taken booster dose. And this is very, very, very clear study which says that booster or the precautionary dose does save you from getting the infection. If you get infected, there is a reduced chance of hospitalization and going into severity of the disease. So what does the ICMR guidelines say about the patients who get diagnosed? And this is about adult patients who are diagnosed with COVID-19. And the clinical guidance for the management of COVID-19 adult patients says that if you got a mild disease, meaning that you have just few symptoms of upper respiratory like cough and not having fever, not having any breathlessness, or there is a drop in SpO2, the only recommendation is that isolate yourself so that you don't infect to others who may be more prone for severity of the disease. And you have to continue taking COVID appropriate behavior, and at the most you can do some symptomatic management of cough by taking cough syrups. For fever, you can take antipyretics and remain well hydrated. The important thing is that even if you have got a very mild disease, not much of symptoms, always stay in touch with a physician and continue monitoring your temperature and oxygenation, because further course depends on how you feel. So if you have a breathlessness and your oxygenation goes down below 93%, or if your symptom persists for more than 5 days, you have to seek medical attention. And this may be low threshold for those who are high-risk patients. We'll see who are these high-risk patients. And at the most, if you have a cough and it persists for more than 5 days, we have got a very robust data from the STRIKE study that you can take inhalation budesonide up to 800 micrograms twice daily for 5 to 10 days. And this can be taken in the mild disease if you have a very bothering cough. So which are these high risk groups which we keep on talking, who are more prone to get severity of disease and likely to have an adverse effect of this virus? So these are the elderly population, more than 60 years, those patients who have active tuberculosis, who have pre-existing chronic lung, kidney, or liver disease, or some cerebral disorder, those patients who are obese, immunocompromised, such as having HIV patients or having undergone transplants of organs, patients who are diabetic, or those who are having cardiovascular abnormalities like hypertension, ischemic heart disease, or some such affected disease. So these are the likely patients who get severe, and these are the patients in whom we talk that they are comorbid patients. So we use the term moderate COVID disease when you are more tachypneic, your respiratory rate goes more than 24 per minute, you feel breathless, and your saturation, when you monitor with a finger pulse oximeter, you find that your oxygen saturation goes to 90% or less than 93% even on room air. And these are the patients in whom we advise hospitalization immediately and give them oxygen support so that they maintain at least more than 92%, and the target for those who have got pre-existing lung disease should be 88 to 92%. preferably use a non-rebreathing face mask. And in these patients who are not desaturating, encouraging awake proning will actually improve their hypoxia, and there should be sequential position change every 2 years. Then you can use anti-inflammatory drugs like injection with prednisolone in the dose of 0.5 to 1 milligram per kg in 2 divided doses or equivalent of dexamethasone. You can switch to oral dose once patient becomes stable and discontinues steroids as soon as oxygen supplementation is not needed, because we have seen that indiscriminate use of steroids can lead to secondary infection, bacterial infection, and fungal infection like mucormycosis. So one should watch out for this when we are using the steroids. We need to give anticoagulation for all patients who need oxygenation, but you have to confirm before you give anticoagulation therapy that there is no contraindication of its use and of high risk of bleeding. So what we advocate is prophylaxis with unfractionated low molecular weight heparin, which should be weight-based. And you continue to monitor these patients, see their tachypnea is improving, whether they are hemodynamically stable, and adjust their oxygen requirement accordingly. You can take help of imaging at this stage and may do a serial chest X-ray or low-dose CT if things are not improving, and keep a tab on labs like CRP, T-dimer and blood sugar, and kidney and liver function test maybe every 1 or 2 days. And once they improve, get a discharge as per the discharge criteria, which has been given out. Some of the patients really go for severe disease, and now these patients show much more breathlessness, which tachypnea being more than 30 per minute, feeling breathless, and SpO2 is about 90% or less than 90% on the room air. This is the patient in whom you should shift them to a high density unit or ICU. Maybe we will require, along with oxygen support, some non-invasive ventilator support or high flow nasal cannula based on oxygen requirement and their work of breathing. Some of the patient may need intubation and may go for invasive mechanical ventilation. In the terms of anti-inflammatory therapy, we may have to augment the dose of steroids or methylprednisolone to 1 to 2 milligram per kg to be given in 2 divided doses. But here again, a word of caution that you should watch out for secondary infections, bacterial infections, and mucormycosis. And the supportive therapy that works is that keep these patients well hydrated, keep them euvolemic, and an antibiogram for sepsis or septic shock or an appropriate antibiotic can be added to your management protocol. Continue to monitoring them clinically. They see their work of breathing, which is improving. See if they are hemodynamically they are stable or not. Continue to adjust oxygenation and make use of imaging and labs to keep a tab on these, because these are the patients who are likely to have to be facing death. And try to improve, and then after they improve, discharge as per the revised criteria. So we can ask that what are the promising new drugs which are there, and these are in the form of antivirals and some cocktail antibodies. So this is about recommendation about remdesivir, that it is continues to be advocated in all the protocol, and this is only with only in patients who require supplemental oxygenation but are not on invasive ventilation or ECMO, because the window of its effectiveness might have been passed by the time patient goes in for ventilation and such advanced mode of ventilation like ECMO. Hence, it's to be used within 10 days of onset of symptoms with moderate to severe disease. It's to be administered for not more than 5 days to treat hospitalized patients. And of course, not to be used in patients who are not on oxygen support, or of course, it's contraindicated to be given in home setting. The recommended dose, as we all know, is 200 mg stat followed by 100 mg twice daily for about 4 days. Don't use, there is no usefulness of it using for more than 5 days. So this was the statement of the manufacturer of remdesivir They have done an in vitro study, and this has come after the Omicron surge happened in the world. And what they say is that remdesivir will continue to be active against the Omicron variant, and they are going to conduct laboratory testing to confirm this analysis. And this is based on the genetic information available of the Omicron, this variant, and the target protein that it gets attached to. Then there is a highly controversial drug, molnupiravir, which has come, and it has come as a therapeutic indication in patients for treatment of adult patients with high risk of progression of the disease, including hospitalization and death, to be used only in those patients who are comorbid, and has to be administered within 5 days of onset of symptoms, and not for more than 5 days. Not to be given for women who are ANC, PNC, or prospective mothers. It is not for pre or post exposure prophylaxis for prevention of COVID-19. So don't start taking it once you think that you have come in contact with the COVID positive patients. A very special word of precaution for females of childbearing potential. They should not be given, and even in also males, if he is used and is of report and has a reproductive potential, they should use some barrier method during treatment and for up to 3 months after the final dose. So this is what is known about this drug, and we have an advisory which has been given by the Public Health Department of Government of Maharashtra, which has advocated the use of molnupiravir in mild patients having comorbid. So this direction says that it's an antiviral drug to be prescribed for treatment of mild illness, not requiring oxygenation, one or more risk factors that will cause hospitalization and impending severe disease, and in whom there are no other options available, and when there are no contraindications to the use of molnupiravir in the first 5 days of the illness, and patient qualifying for the above criteria should have a definite COVID positive report with them, as this has shown to reduce hospitalization in clinical trial and thus has received emergency authorization. So the alert is that many of the states, even in India, are not using these drugs, and ICMR has not recommended its use in the treatment, and it's not included in the standard treatment protocol released by Government of India as a letter says 17 January, which I was going through. So this is because it is contraindicated in patients of childbearing, so ANC, PNC, and prospective mothers, and even in the males who are likely to have a reproductive potential. So these are the concerns, and this is because of the mutagenesis on its mutagenetic effect on the reproductive cells, such as males and female gametes. And secondly, the fast dividing cells may accumulate mutations in bone and cartilage. And the most important, which has not been highlighted while using molnupiravir, is that when taken in a suboptimal dose, it's likely to cause sublethal mutations and perpetuate further variants of the virus. Hence, it's very, very important to take full course of 40 capsules once the medicine is started. Don't take it in a suboptimal dose, or do not just take the full course and just complete it. Don't stop it in between, because these are the problems that can happen. Then we have a new effective drug, which has been also US FDA has given emergency authorization, which is not currently available in India, is Paxlovid, which is a combination of two drugs. One is nirmatrelvir and ritonavir, which is the drug which is already being used in HIV. These are all protease inhibitors and are co-packaged, and these two tablets are to be co-administered simultaneously. So what is the positioning of the Paxlovid? It's for treatment of mild to moderate coronavirus disease in adults and pediatric patients of more than 12 years of age. with positive report and who are at high risk for progression to severe COVID-19 infection, including hospitalization and death. We have seen what are the risk factors and what are the comorbid patients in which it can be used, as demonstrated in the earlier slide. Again, it's not to be used in the females of the reproductive age group, but it's effective against patients of both Omicron and Delta virus, and we have got a confirmed proof of that. It's contraindicated in some of the drug to be taken with some of the drugs. So there are some significant drug-to-drug interactions, not to be given in hepatotoxic patients, and this may potentially have a drug resistant developing if it's given in a HIV co-infected patient, and it's to be used with caution. So this is to be given. So both the tablets are to be given simultaneously. So 2 tablets of nirmatrelvir and ritonavir. So total 3 tablets to be given twice daily for 5 days. Administered within 5 days of onset of symptoms and not for more than 5 days. Is antiviral. So this viral replication phase is only in the initial 5 to 7 days, and hence should be given within that window period. It is not for pre or post exposure prophylaxis for prevention, and it's certainly not a substitute for vaccination and not to be used in severe kidney or liver impairment, which is in contrast to molnupiravir, which can be given irrespective of kidney, liver, and age factor. So this is a recent study which has come up and which studied this remdesivir, molnupiravir, and this nirmatrelvir against the variants of concern like Omicron and others. And these results indicate that when more variant of concern arise due to antigenic drift, there is a high probability that they will remain sensitive towards the current antivirals because they show that their activity against alpha, beta, gamma, and delta variant. And this is because they have found that the target proteins of these antivirals are highly conserved, on which these drugs have action on. What about the antibody cocktail? This is a cocktail of casirivimab and imdevimab, which is currently available in India and has been approved in more than 20 countries. And this NIH actually strongly recommended the use of this cocktail also in the post-exposure prophylaxis, and has got a very effective treatment also result. So it can reduce hospitalization by 30% in the group that it was used, and hence it is now also indicated for post-exposure prophylaxis. So this cocktail is indicated in adult of post-exposure prophylaxis in individuals who are at high risk for progression to severe COVID-19, including hospitalization and death. And these patients, these cohorts of patients are those who are not fully vaccinated or who are not expected to mount an adequate immune response to also complete this COVID vaccination, or those who have been exposed to an individual infected with COVID, like having direct physical contact with the person affected or COVID positive, sharing, eating, or drinking utensils, or has been exposed to respiratory droplets from an infected person. And this is post-exposure prophylaxis is for those who are at high risk of exposure to an individual who are infected with COVID because of occurrence of COVID infection in other individuals in the same institution setting, for example, nursing home, prison. So if you've got a group of people getting infected in an institutional setup, even this cocktail can be used. The limitation of its use is it should not be substitute for vaccination, and it is not authorized for pre-exposure or prophylaxis. And there are some questions about its use in Omicron because it's not, although manufacturer claim that that's got an in vitro effectiveness against Omicron, but because of the mutation, this cocktail may be rendered actually not very effective. So as we have given it in many patients, it comes in a dose of 2. So 2 individuals can be given in a one dose. That is another limitations because of the cost factor. And the 600 milligram of each of these individual antibodies are to be mixed and to be given together as IV infusion, in which form it is available in India and not a separate infection in India. And the initial dose is to be given for 20 minutes, about 150 milligram per hour, and then the speed can be increased. It can be given over the period of 1 year. It can be period over about 1 hour, 1 to 2 hours, and it's quite safe. Doesn't cause much of problem. And now we have experience of so many cocktails being used, so this is good. This is the update that the administration of a booster or precaution dose compared with not receiving one was associated with significant lower rate of COVID infection. So there is always a doubt about the vaccine query. What is the best timing? So as of now, Government of India is saying that 9 months after your second dose, you are entitled if you are a frontline worker or a healthcare worker. And what is the benefit of third dose can be queried in mind, but even if we have got other immunity in place, so we think that vaccine could continue to protect many recipients from severe diseases and deaths from COVID-19. And you should also know that some of the antibodies cannot be measured. Like in addition to antibodies, the immune system, which is previously infected and vaccinated, and those who have been vaccinated, they can deploy the cells called as T cells. These T cells have got memory T cells, what we call. They can actually recognize even the fragments of the viral protection and destroy virus infected cell, potentially limiting the scope of an infection. So this is an intangible measured T cells which cannot this immune response cannot be measured by any test, but is present in individuals. So even if antibodies are being considered, we have another defense line in our body which can fight this, and we can fight COVID infection. These are memory T cells. So to just have a take-home message of my talk, I can end it on a very optimistic note that the Omicron could be the beginning of the end of the pandemic, and we are perhaps on the eve of a turning point which could be decisive in passing from a pandemic to an endemic phase. And Omicron could be the beginning of the end of this actually pandemic, and because it's very contagious but is less dangerous. But of course, with the same breath, I should say that there's no reason to let our guard down. But also, it is not a reason to become an alarmist and undue cause what to call a sense of alarm in others. So on this balanced note of caution, I end my talk. Thank you, viewers. Thank you, audience, for your patient listening. Thank you.
Thank you, Dr. Rajesh. Thank you for the talk, that very informative talk. Do we also have Professor Ravi here? Yeah, he is here, but I don't know if he's going to be coming live. So we do have a few questions, Dr. Rajesh.
Yeah, I'm there to answer it.
Thank you, sir. So first question is, what has been your personal experience with Omicron patients during this past 1 month? Have you seen any? And how complicated are those cases? How do they recover? Is there any difference between the previous wave and the patients in this wave? Could you just share some light on that?
Yeah, so there is actually a lot of difference between what we saw in second wave and now what we are seeing. It is basically a large difference. We started in our region, and because India is a big country, you will have, I think, various phases of this pandemic. So, of course, in state of Maharashtra, it all just began with Mumbai, and we had experience of also been there, also of them. And then what we saw is the infection is, as is now known, is very mild, in fact. So, for example, I can quote my region when in the second wave, when our figures touched about 3,000, 4,000, our OPD was full, our hospital beds were full. Now it is the same thing which is there. We are almost at that number in third wave. But I hardly see many patients in OPD. So now it's about 4,000. We are now logging 4,000 per day as of now today. And still we don't find many patients who are in OPD. It's almost not even 1/10 of what we used to see of course, in what you call the way that we saw. And moreover, what we are seeing is that people are getting okay by just about 2 to 3 days. So peak, they have got fever for 1 or 2 days, I think just itchy throat, and they get well, I think within 3 days. And this is experience because even our staff is getting infected and they have to report back. So we are asking them to come after about 7 days, and they are quite fit and hardly any ICU admissions. Those are there who had incidental COVID positive. They had come for some other reason like heart problem or some chronic lung problem, asthma attack. And then we found them to be incidentally also positive actually with COVID. So these are the patients who are there in my ICU, not the patients who are actually sick per se because of the COVID.
Got you, sir. Got you. So there's one specific question from Dr. Ahmed. You have already shed light on molnupiravir, the contraindications, the use of molnupiravir. His question is very specific. Are there any cardiac risk factors for molnupiravir? Are there any cardiac contraindications for that particular drug?
So in fact, none. So molnupiravir is actually a very safe drug. In fact, in terms of, it has got no drug-to-drug interaction. It can be taken in patients who have got also deranged hepatic enzymes, or those who have got also abnormal kidney function test. It can be used safely in also elderly people, doesn't have any interaction with food. So as such, it doesn't have any of the contraindication. The only thing that we are worried, and it's also not proved, but we take any of new drug with utmost caution, and it has got emergency use authorization and not the approval of FDA, as has been told. So we have to use it by caution. And as I also entitled in my talk, that it's not to be given for those of us people who have got also who are in ANC, PNC period, and also what we call reproductive age group. But of cardiac abnormality is not a contraindication for giving molnupiravir.
Correct, sir. Dr. Rohit Raja asked us to share the new circular. I believe he's talking about the latest ICMR guidelines. Dr. Rohit, I'll be sharing it on email with everybody after this particular webinar. So please bear with us for the time being. One more question from Dr. Vijayarani. What are the recurrence chances of Omicron, and what could be the long-term complications? I know it's too early in the disease to actually say that, but recurrence chances honge, just throwing it out there.
Yeah, so as Dr. Ravi told, in fact, that any of what we call prophecy that we do about the virus can shoot you back in your own mouth. So I would also be wiser from his experience. But of course, till now we have got, for example, in our region in Maharashtra, we have got only Omicron now. So because there's a lab which is doing sequencing, and then they have found it out that almost all the cases are of only Omicron, and none have got reinfected. So I haven't got any of the patient or any of the reports which is there, because I think many patients actually might have got Omicron, but none till now. But it is too early, as you were saying rightly, Nilesh, that it's only 1 month's time, and it can come again, and with what intensity it comes and how it behaves is anybody's guess. But I think that we have to move to, I think, vaccination. So I think this is a time to reinforce actually the need of vaccination, everybody, and already we have also reached what we call milestones. We are fast approaching these are the milestones of vaccination every day. and I think that will take care of it. So I'm quite optimistic. With the same breath that yes, we also just should not do any of the prophecy, but I think I'm just taking from the experience of what we had because Spanish flu way back. So after third wave, it got waned off, and then we didn't hear of it much. So just extrapolating that experience and also expecting this other virus to behave same way. I think that won't happen, and if it happens, it will be quite mild infection. And now we are also doing then also vaccination, so that will take care of its effectiveness.
Right. So these were the main clinical questions. But I would like to ask you one last question before I let you go. It's another problematic question. What do you think about herd immunity? Will this pandemic get over sometime soon? I know it's just looking in the glass bowl, but will we ask your thoughts on that?
So herd immunity is only specific to that, I think, variant. But if suppose coronavirus is going to throw us this different variant of concerns, I think by that time we would develop herd immunity for one variant. It will have another thing variant. So again, as also Dr. Ravi was telling, I think I'll go by saying that herd immunity. I think we had already achieved it before this Omicron came, because we had a plenty of infection which was there in also second wave. We then also had what we call vaccination. So I think combining two, we already must have achieved about 60 to 70% herd immunity, but still Omicron hit us, right? And it was hitting it hard. So this, I think, concept of herd immunity is evasive, I think, and even I'm not yet able to believe it that it will happen, because it will throw various variants, and then again we'll have infection because of that.
I totally agree, sir. It's a dream for us कि सबको herd immunity हो जाएगा और कोई भी COVID नहीं होगा. But जैसे variant आते रहेंगे, वैसे you need to develop the immunity once again. The T cell immunity might stay, but the particular antibody immunity will have to keep coming up.
Yes, it's very important to remember that we have got to also look at defenses. And for not only the antibodies, we would only just measure antibodies, but there's also something else which also cannot be measured, and that's T cell immunity, which is also memory cells, and it also memorizes even also what to call a smaller part of also this thing of variant, and it can also protect us from any of the feature variants. That's for sure.
Thank you, sir. It's been a pleasure having you, Dr. Rajesh. Thanks a lot for your time. I really want to do more such webinars with you in the future, so please do shed some time for us. Professor Ravi has just left the webinar, so thank you. Professor Ravi, are you around? I do not see him. I mean, I see him, but his audio is not there. I just wanted to thank you, Professor Ravi, for this. Thank you, both of you. Thank you, the audience, for listening into this. Have a good day ahead. Thank you.
Thank you. Thank you very much, Nilesh. Thank you. It was a pleasure. Bye-bye.